So I'll be speaking, limbo keratoplasty, meaning we are using a donor tissue limbus along with the corneal transplantation. So we are basically repurposing this technique for a sclerocornea. Do not have any relevant financial disclosure. As we all know, sclerocornea is one of the very rare, severe form of an anterior segment abnormality, wherein you have a dense corneal opacification, extensive vascularization, ill-defined limbus with a poor limbal analgae. All are high risk factor for a corneal transplantation. And cases which have a peripheral corneoscleral adhesion, that is an independent risk factor for not only for a glaucoma and also graft failure. Therefore, we have to have an alternative to the penetrating keratoplasty. This is a phenotypic description of a typical sclerocornea. You have ill-defined limbus, anteriorly inserted conjunctiva. Such a conjunctiva not only makes surface is a pore and also brings in lot of blood vessel into the cornea. You could see here ill-defined limbus. When we measured limbal analgae in these cases, they were extremely deficient. It's also important to perform a UBM in such cases to pick up extensive peripheral iridocorneal adhesion. These are one of the biggest risk factor for a graft failure. This has to be distinguished from the peripheral sclerocornea, where central cornea is relatively clear. You do have a ill-defined limbus, and if you look at the entire limbal analgae is stretched. Not only they are poor, and also they are anteriorly inserted. In this particular instance, we don't have to perform any transplantation. All they need is a refractive correction. Again, a slit wave showing a discoid shape configuration with the center being more thicker than the periphery. So the histopathology again shows an abnormal thickened epithelium, and there are debate whether they belongs to cornea or conjunctiva. Bowman's membrane is entirely destroyed, and these fibers not only irregular and thick, they are almost reminiscent of a sclera. And as I said, an entire pancorneal vascularization, both from episcleral as well as a conjunctival. And in these cases, desmet is found to be rudimentary or completely absent. In addition, you have a iridocorneal adhesions. All these factors makes the corneal transplantation abysmally poor. As Dr. Rao was alluding, there are cases we need to know when not to do corneal transplantation. I think this has been largely practiced. The sclerocornea means we were never doing any transplantation in such cases. Why do they have such kind of an abnormal? We did even immunophenotyping in these cases. Although all stromal elements natively belongs to cornea, they have an additional sulfated keratin sulfate within the extracellular matrix that makes these collagen fibers are wavy, irregular, that lead to loss in a transparency. And this subset of cases can also have a poor limbal analgae that lead to the primary stem cell deficiency. This particular work I pursued when I was with Ken Nischel. So this particular video you are showing a normal architecture of the limbal analgae, what we call it as a palisades. And in a patients with the sclerocornea, they have a extremely poor palisades. To maintain the normal corneal homeostasis, we need to have a 5 to 6 limbal palisades for every square millimeter. That helps in maintaining the corneal epithelial milieu postoperatively. With this background, this is one of the cases to show congenital aniridia having a primary congenital deficiency. These cases, if we embark on a corneal transplantation, 100% they fail. So why do we have a sclerocornea? As I said, it's basically developmental abnormality, which one of these transcription factor primarily regulate the primordial cells, which in turn work on a neural crest cells in a downstream pathway. Because if there is a failure in a migration of the neural crest cells between 6 to 8 weeks, that lead to the what you call as a typical sclerocornea. And published literatures have shown within first year, nearly 70% of these grafts fail. So with this background, we wanted to actually address not only the central corneal visual axis and also limbus. So this is one of the index case where showing ill-defined limbus, poor limbal analogy. And in the left eye, we can actually see a sliver of a limbus with the limbal pigmentation. This is a surgical video, a very classic case of a sclerocornea. We need to ensure and respect the anatomical landmark. We are not only preserving the recipient's limbal stem cells, although which are abnormal, and we are also supplementing donor limbal stem cells. Thankfully, we have an access to high quality donor tissue, as Dr. Rao was mentioning, and these donors should be very young, less than 30, with a DPT of less than 6 hours, at least a one quadrant of a limbus, healthy limbus. I generally always superior limbus that is well protected under the upper lid, oriented. Rest of the steps are similar to any transplantation. Post-operatively, I also supplement them with a specialized contact lens. And in one of the the child had lost the contact lens. You can see a florid inflammation with all loosened suture. Meaning, this contact lens, like similar to the keratoplasty, if we continue for a long time until all sutures are out, it actually minimizes the surface inflammation and also prevent the irreversible rejection. This particular child doing extremely well with this 5 to 6 millimeter graft, and there are numerous such examples. In interest of the time, so mostly the children who are between 3 to 4 months, most of them have a total sclerocornea, and most complications were seen in the first 6 months to 12 months, and nearly 90% of the rejection end up having a failure in such cases. In comparison to the literature, at the end of first year, we had a graft survival 68%, second year 58%, and nearly 50% of them had during neuroplasticity within that 3-year time frame. Even if the graft fails, you have a window of opportunity to revisit such cases. So one of the index case has completed 5 years with a good specular, doing exceedingly well. To conclude, children with a significant total corneal opacification due to sclerocornea can help not only achieve a good anatomical outcome, so is a functional outcome. And some of the measures, both topical and a systemic immunomodulator, are key. There was a concept, Dr. Rao would agree with me, in late 70s and 60s, there is an immune privilege within that critical time frame before even the lymphoid, that is the cellular system, sets in. If we can identify that critical period, so we can actually evade the risk of rejection. And this definitely ensure achieving a long-term outcome in this rare and difficult cases.